you've got two things that are fighting against you and compressing the nerves. Well, the third thing that then fights you is from the front, the disc. Remember, the disc was starting to degenerate and bulge. So now the disc is bulging towards the central canal. So the end stage of all these things happening as your disc degenerates and your spine wears down is things get narrower around the nerves. That's called spinal stenosis. Okay? So stenosis refers to narrowing of the canal. So what you see here is that the ligament has started to push in and sort of cause a indentation of the sac here with the nerve roots in it. The joints, it's not pictured here, but the joints are getting larger and they too will push in towards the sac. And then the disc will start to bulge and push into towards the sac. So when you look at an MRI of somebody with spinal stenosis, instead of having a nice big open circular area in cross-section where you see lots of white or fluid, you see a little black dot. Okay, that's a severe spinal stenosis. All right, so it's a narrowing that's caused by degeneration. So the disc, the facet, the ligament, and then the bone spurs. Okay, now what do patients with this diagnosis typically feel? Well, sure, the nerves are being pressed on. It's now narrow, so at that respective level, you can compress those nerves passing by, right? But also, typically, these patients have a limited walking ability. Their distance is limited in terms of what they can walk. So they'll say, I can only walk 1 block or 2 blocks, and then I have to sit down. Well, then my next question is, well, after you sit down for a bit, can you then get up and go again? Okay? It's very classic for stenosis because when you sit down, you tend to bend forward. When you bend forward, you open up the canal and sort of allow for signals to go through the nerves. So then you can get up and walk again for your tolerance. You walk another block, then you have to sit back down. So that's classic. Limited walking tolerance, and when I sit and rest for a bit, I can then get up and go. In addition, I mentioned to you that those patients feel better when they flex forward, right? So what do when they're in the grocery store and they have a shopping cart in front of them? They rest their elbows on the shopping cart. So that's the shopping cart sign. Okay. The other sort of hard thing for patients to describe, but they definitely do feel it with this diagnosis, is you have a vague sensation of weakness and fatigue within your legs. Your brain is saying, let's go, I got to walk down this block, but your legs aren't following along. Okay, so that also goes with the narrowing of the canal, or the stenosis. All right, so that I went over all those symptoms. That's what I just talked about here. So those all refer to stenosis. Now, the reason why stenosis is found in other diagnoses is because what if I have a huge disc bulge that's sitting in the canal? Well, that's also causing stenosis, right? That's narrowing the canal, the central canal through which all the nerves are passing. Okay, what about degenerative spondylolisthesis? How many people know the term spondylolisthesis? Okay, how many people know the term slip disc? One and the same. Okay, so often called a slip disc, it doesn't mean that the disc is slipped. It actually means that one bone is slipped forward with respect to the other, or maybe multiple bones. Okay, so when we break down this term, spondylolisthesis, spondylo refers to the vertebrae, listhesis refers to translation. Okay, so it's one vertebrae moving forward on another. Classically, degenerative spondylolisthesis happens at L4-5. If you look at a biomechanical model, this is where most of the stressors occur. The facet joints in the back start to lose their capsular support. The capsule starts to stretch out, and then the facet starts to open up, and the bone starts to creep forward. Okay? The way I explain this to people is, normally, this is one bone, this is the other. When you bend forward, they go together. When you bend back, they go together. If you have this slip, you're slipped already when you're standing, and then when you bend forward, the top one may slip forward even further, okay? Well, it's not like these bones aren't attached to anything, right? They're attached to the back part of the spine. And what's contained between the back part and the front part are the nerves that pass through. So obviously these nerves get tensioned when the bone slips forward, okay? So the best way to depict this is if you look at this picture right here, this is looking at the spine from the side, but it's sort of a cross-section over to one side, okay? And so you see here, this black dot is the nerve root. The white is the area around it, or a nerve sheath. Okay, lots of white means lots of space. The nerve is not being compressed. So normal level at which there is a spondylolisthesis, you can see the nerve is that small black dot up there, and there just isn't the room here as there is here. Okay, so as a result, with the slip disc, so let's say the degenerative spondylolisthesis is at L4-5. Classically, you get the L4 nerve root as it comes out at that level. and then you get pain in the inside of your calf. But, as I mentioned to you, some people can also have stenosis with other diagnoses. So because it's slipping forward, see how this bone is forward with respect to this one? This area can narrow as well. Okay? The central canal can get narrow, and then you have stenosis. So then you may also get the 5 nerve as it crosses through there. So then you have pain on the inside and the outside. Okay? So what do you feel in this case? Well, you may have some decent amount of back pain because it's unstable, right? There's more motion in it than there should be. You may get leg pain associated with it, like I just talked about, and it may be positional. So depending on the position you're in, you may have worse pain. In particular, when you move forward, you put more stress on the nerve that's exiting out, so your pain may increase. Okay, what about degenerative scoliosis? So typically when we think of scoliosis, we hear this term in our adolescence, right? The schools do screenings for scoliosis where they use a scoliometer, run it up and down the back of children to see if they have any curve. That little ball goes side to side, right? So this is not the same thing. That's adolescent, sort of, we call it idiopathic scoliosis, or it may be from birth, so then it's neuromuscular scoliosis. This is different because it's degenerative. It's happened from wear and tear over time. And what happens is you get a curvature to the spine. So sometimes you can see it just from looking at the back, okay? If you look at the patient and just feel for their spine, you can feel it curve to the side. Other times the patient says, well, I just can't go, I can't lean to one side as much as I can to the other. And the main difference between this kind of scoliosis and the one in kids is that this is rigid. That one is flexible. So if you get a bending film on a kid with scoliosis, sometimes you can straighten them out. On an adult, when you get a bending film, they're often very rigid and they don't straighten out. How does this happen? Well, basically it's from asymmetric wear and tear of the discs. You can see here that these discs are more collapsed. Or it can be from asymmetric formation of bone spurs. Okay? But as these discs collapse on the inside, the nerves that come out from this area are going to be more compressed than the ones on the outside. Right? You can see that. Just from here to here, there's more space than there is from here to here. Okay? So initially this may present as back pain, and then over time you may get a leg pain component if some of the nerves are being pinched. So there can be some level of rotation associated with this as well, you know, like when you're looking front to back, as well as from side to side. You see this curve here. So typically patients experience back pain, stiffness, in particular, like I mentioned, leaning of the trunk to one side is difficult, and you may have the leg pain associated with that. All right. Okay, what about compression fractures? So this is a problem particularly in the elderly, and that term is always relative, right? It's always shifting. So when we talk about compression fractures, by definition what you mean is that the front third of the spine, okay, if we divide the spine into columns, 3 columns like this, and this third column, the anterior or front third of the column is compressed, okay? The bone is actually fractured within the body, the vertebrae, all right? So how does this happen? Sometimes you see it, in particular in elderly females who were walking in an upright posture, then they come in to see you in clinic and they're hunched over and they say, I have a lot of back pain right in the center of my back. That's sort of classic presentation where you should get some kind of screening test, whether it's an X-ray or an MRI, to look for a compression fracture. You can get it from a fall. In particular, if somebody falls out of bed hard onto their buttocks, a lot of load is transmitted through the spine. So if you get this, if you sustain a compression fracture from a standing height, okay, then by definition you have osteoporosis. And you should see your doctor, your primary care doctor, to get worked up to see what your bone metabolism is at. So everybody here knows what osteoporosis is? Yes? Anybody that does not know? Basically, we just know that it's the bone turnover is enhanced so that the breakdown is higher than the makeup, right? So you're breaking it down faster than your body can regenerate. So people who may have this or are at risk for it are those that have had a hip fracture from a standing height fall, or those who have had a wrist fracture from a standing height fall, okay? And then what do you feel? Usually it's intense, it's sharp, it's stabbing back pain, it's point tender. So as you examine that patient and sort of thump down the spine, they're point tender at the location of the fracture. It can come on acutely. It's difficult to hold yourself upright, and typically there is no leg pain associated with it if it's only up in the front of the column of the spine. If it is involving this portion of the spine, the fracture extends into there, then that changes it. It's not a compression fracture, it's a burst fracture, and then you can have pressure on the nerves from that. Did you have a question?
Yeah. Can that be in the thoracic spine?
Yes, certainly. It can be at any part of your spine.
Right.
The thoracolumbar junction is the most common location of these types of fractures. So where the thoracic spine goes to the lumbar spine. Okay? One more diagnosis. This is the last one. So SI joint arthritis or SI joint syndrome. Everybody familiar with the SI joint? So SI stands for sacroiliac joint, okay? It's where at the bottom of the spine you have the sacrum. The sacrum joins the pelvis at the sacroiliac joint, okay? You see it here and you see it here. These are all different variations of how you see it. Basically, this is a joint that naturally does not have a lot of motion into it, has a specific type of rotation and shear motion to it, okay, if it moves at all. And you can have breakdown of the cartilage or degeneration of the cartilage within this joint. Typically it presents as one-sided pain, okay? It's sort of low in your back and one-sided. In men, it can radiate into the groin and sometimes into the testicle, okay? Things that are classic for it are you have difficulty stepping up, going up a stair, okay? Rising up from a seated to a standing position. Difficulty sitting with your legs crossed. Can mimic as hip pain. So those are the classic symptoms, and typically patient will say, oh, well, I get relief when I lie down because they're not loading that joint. So when we see people in clinic, even if we see them for back pain and we see something on their MRI and it looks like it's back pain, we also examine them for their SI joint to see if that's what's provoking it. So there's certain maneuvers we'll do to a patient. For example, have them put their one foot over the other leg and then press down to load that SI joint in the back. And there's other specific tests we do to try to isolate it and see if that's what's responsible. The reason why this has become more prevalent in terms of our diagnoses is that we now have a newer treatment for it that's relatively less invasive, and for that reason we look for this diagnosis because it's an easier diagnosis to treat sometimes than maybe a multi-level lumbar spine problem. Okay? So again, managing back pain rests on the same principles and tenets that we talked about for neck pain. Anti-inflammatories, physical therapy is key, okay? In particular, in those patients, younger patients who have one disc that's broken down at a young age, and they say, well, I have back pain, and the doctor says, well, I'm not going to do surgery on you. And they say, well, where's it coming from? It's coming from your back. Well, then why can't you fix it? Because if I fuse you at that one level, you're going to start a cascade of breaking down at the other levels. Well, what do? I'm going to live with back pain for the rest of my life? Well, this is what you do. You do physical therapy, okay? And you strengthen the core as much as you can. What do we mean by core? We're talking about the abdominal muscles, and we're talking about the extensor muscles in the back here, okay? And basically, by strengthening those muscles, you can support the spine in absorbing the loads that it normally takes when you're walking around and doing the things that you normally do. Okay, and then epidural injections, I discussed with you guys already how we use those. Though it's an injection and it is a procedure, it can be very telling of where your symptoms are coming from. So, you know, if you're ever concerned about getting it, ask your physician, well, why are you suggesting this? What do you intend to do with the information you get from it? How will it change your treatment paradigm? Okay? I think, so I'm at an hour. I'll just quickly touch here. So kyphoplasty, this is a procedure that we use for compression fractures, okay? Basically, it's injecting cement into the bone and helping to harden that area where there was a fracture. I reserve it for specific patients. It has to happen close to when the fracture happened, okay, in order for it to be effective. But keep in mind, you're putting a cement block in somebody's spine that's already fragile. Okay, so obviously this bone and this bone now have a cement block in between them. It puts a lot of load on those native bones. Okay, so just keep that in mind. And this was the procedure I was talking about that you can have for the SI joint. It's called a minimally invasive SI joint fusion. Basically, these are 3 titanium coated rods with a product that allows for bone on growth, and it helps fuse that joint to eliminate the motion that's painful there. Okay. I didn't go into these things, but you can see here pictures of why you would do fusions, okay? One sort of word of advice I'll leave you with is, in the media there's a lot of bad press towards the term fusion, but there are certain indications where fusion has a great success rate, okay? One of them being the slip disc, okay? There have now been randomized, controlled, multi-center studies done on this particular diagnosis, and treating these with a decompression where you take the pressure off the nerves and then fuse that portion of the spine has a very, very high success rates in the 90 percentile. So don't let the word fusion misconstrue what your diagnosis or what your treatment is. Just ask your doctor about that. Why are you suggesting a fusion? What is my potential success rate with this fusion? What's the goal of this fusion? Okay? I think that covers everything. Okay, so that's about it. All right, so thank you guys so much. Any questions about back pain? Yes?
I've had on and off low back and sciatic pain for about the past 15 years. And lately the condition has been worsening, so that's concerning me. A couple of questions. First is, I'm wondering if you can tell me why I would experience much more back pain at night, so towards morning or in the middle of the night, and more than I do in the daytime?
Mm-hmm. Well, it's hard to sort of answer that question without knowing specifically what your spine looks like. We talked about nighttime pain and where it can play a role, but I'd first look at your images before I even started to give you an idea of that.
Okay, and then the other question was, I'm wondering if with my condition it would be wise to see a neurologist. I did have an MRI done about 10 years ago, and it's showing a lot of arthritis, disc degeneration, disc space loss, bulging disc, facet degeneration, and canal stenosis. But would a neurologist be helpful?
Yeah. So the reason is, so it's nice to have both things going on in concert with each other. The reason is because obviously a spine surgeon gives you a surgical perspective, but they can also explain to you where they think your pain is coming from. A neurologist tends to look systemically at the whole nervous system and see if that's responsible for what's going on. In particular, there should be certain cases where a spine surgeon says, you know what, this is atypical, we better check with the neurologist to see that there isn't something else going on. But if you have findings on your MRI that can kind of explain what's going on, then you may not benefit from the neurologist as much. In particular, if I see somebody with neck pain and they say I have a lot of headache component to it, then I say, you know what, you need to see a neurologist to make sure there isn't something else that's responsible for it. So it all depends on your specific situation.
Okay, got it. Thank you.
Yes?
Can physical therapy help sciatic pain?
Okay, so you mentioned sciatica, and so now that you said that, I'll address it. So sciatica as a term, okay, refers to compression of the sciatic nerve as it exits your pelvis. Okay, so the sciatic nerve is a combination of various lumbar nerve roots that then conglomerate into one big nerve that runs down your leg. So sciatica refers to compression of that nerve as it exits your pelvis. For example, you may have an accessory piriformis muscle or an enlarged piriformis muscle that's in your pelvis that's compressing the nerve here. If you have compression of the nerve root up in your lumbar spine, okay, that's radiculopathy. Okay, so there's a difference between the two right there. Okay. Your lumbar radiculopathy may overlap with where sciatic nerve pain runs, which is on the back of the leg and the back of the calf. That same distribution I just outlined is the S1 distribution. Okay, so now going back to your question was, does physical therapy help it? Well, physical therapy can help it if it's coming from the lumbar spine, okay, in the sense that if you have compression of a nerve root or some level of degeneration and the nerve root's being compressed by the disc and you sort of rehab and control your symptoms, then yes, it's helped it, right? I always tell patients that when you come in and you present with a spine problem, if you're worried about undergoing surgery, you shouldn't be, because you can always try those things first. Okay? The name of the game is basically to control your symptoms. If you can control your leg pain and you can control your back pain with some combination of physical therapy, epidural injections, anti-inflammatory medications, then you're in the clear. However, if you try these conservative measures and it continues to recur, then you start to say that, okay, well, the problem is permanent enough or is moved along far enough that it probably needs to be addressed. Does that make sense? So it'll affect your daily function to the point where physical therapy just won't cut it.
With age, can you tell the difference between sciatica and stenosis? What, as you age?
Yes, yes you can, because sciatica, there are specific tests that you can do to look for that. Stenosis, on the other hand, you may get classic patterns of pain distribution, and the best way to tell is to get an injection in the back, and then if you inject at a place where you think it's stenotic on the MRI and you get great relief, well then you've targeted the problem. Yes?
Just wondering, if you have a slip disc or something, this is right, they have all these tests that you want to do, like the x-rays and the MRI and the CT scan.
Yeah.
I really kind of hate to put myself through all that radiation.
Sure. So great question, because it's present in the media all the time. Now a lot of our society is focused on radiation, right? We always worry about, okay, when you go through the airport x-ray scanner, what does that mean? So the one that has the highest radiation is the CT scan. An MRI is taken with a magnet, so there's not radiation component to it. X-ray has a much lower radiation component to it than a CT scan. So as physicians, we also are responsible to our society for cost measures, right? So an X-ray is a great screening tool, right? It's a low cost, low radiation dose, safe way to screen for things. So for example, if somebody has a back problem and they say, well, aren't you going to monitor my symptoms with an MRI every year? Well, no, not at all. You don't need that. Your MRI is only needed if your symptoms change. Well, I have a fracture of my back. Aren't you going to monitor my fracture with a CT scan every 2 years? No, because that's an excessive amount of radiation. So your physician is responsible for interplaying that balance in their decision making. Sure. Yes?
When you talk about medicine to take, like Advil or Aleve or whatever, what is the difference between that and then going to the Celebrex and that type of...
Right, so each of those medications has a different sort of mechanism by which they deliver pain relief, right? So Advil, ibuprofen, Bayer, anything that falls under the NSAID category acts the same way, okay? So it all depends on what you're trying to target. Personally, I ask my patients to stick with those kind of over-the-counter medications as opposed to things like Vicodin and Percocet, because you don't want to develop a narcotic dependence prior to any kind of surgical intervention. Narcotics are reserved for post-surgical pain. When you talk about Celebrex versus Advil, they have different means of treating pain. So it all depends on what you've tried, what kind of side effects you've had. Best thing to do is ask the physician who's treating you, well, which one do you recommend? I've tried this, is that the appropriate one? The other thing you can do is talk to a pain management doctor about what are your options and what are the way these medications work. Yes?
I have copies of my x-rays and MRI and all. If I were to come to your clinic, where would you get new ones or would I bring mine?
It all depends on how old they are. I'd probably first talk to you.